Our next presenter is Dr. David Kuter, who doesn't necessarily need much of an introduction. Dr. Kuter has presented at our first conference in 2019 in Melbourne and has been part of our medical advisory board for a number of years. Dr. Kuter is the Chief of Haematology at the Massachusetts General Hospital in Boston, Massachusetts, and is a Professor of Medicine at Harvard Medical School. In addition, Dr. Kuter sits on numerous national and international committees and is board certified in internal medicine, haematology, and medical oncology. He's dedicated years of effort into researching platelet disorders and in recent years has conducted groundbreaking research when it comes to ITP. As I've mentioned as well, Dr. Kuter also serves part of our medical advisory board, but also with the PDSA in the USA as well. Dr. Kuter will be talking to us today with regards to advancements in treatment and what's the future of ITP in the coming years when it comes to different treatments that are available. So, David, I'll let you take over. Thanks so much.
Good day. My name is David Kuter. I'm a hematologist in Boston, where it's very cold right now, and I'm pleased to share with you the talk on the future of ITP treatments. I wish I could join you in Australia, since I've valued many of my prior trips to Australia to visit my colleagues and also some of the patients with ITP in Australia. In giving this talk, I'm going to talk about scientific things, which I'm going to try to focus at a patient level. And when I do this kind of talk, I sort of try to pretend that the audience, which is you, is my mother. And I'm going to try to explain what I'm going to talk about in a motherly fashion to make sure my mother understands what ITP is all about. Let me begin by saying ITP is a condition which is not that rare and that many of you in the audience experience. These are my disclosures. I work with many different companies and groups that develop new treatments for ITP, and they're listed here. But let me begin by a bit of introduction to ITP. ITP is a disease of decreased platelet production from bone marrow, and also a disease of increased destruction of platelets in the circulation. The bone marrow is the site where platelets are made. This is a cell called the megakaryocyte. It makes platelets, and they're shed into the bloodstream. When ITP occurs, antibodies and lymphocytes attack the megakaryocyte, and this megakaryocyte cell undergoes what's called programmed cell death. It simply dies. And this is called apoptosis, as shown here, but it simply means that the antibodies which are in ITP attack the bone marrow, and ITP patients don't make platelets at the appropriate level. So this is the megakaryocyte in the bone marrow. Now, equally important is the fact that in ITP, platelet destruction is also increased. And this is another cell that has a name that begins with the letter M, called a macrophage. So megakaryocytes make platelets, and as I'll show you now, macrophages destroy platelets. And these cells are spread throughout our bodies. There are lots of them in our spleens and livers. And this is a platelet shown here, coated with antibody, and it's being eaten by this megakaryocyte right here. And this is the genesis of the increased platelet destruction that occurs in patients with ITP. Many of the new treatments being developed prevent this from happening. So many of the new treatments prevent a macrophage from eating a platelet and destroying it. Let me draw this in a bit of a cartoon fashion, if I may. So as I said to my dear mother, here is the surface of this cell called a macrophage. There's a thing called a receptor on it, and here are some platelets. If you have ITP, dear mother, antibodies are made. They then attack the platelet. They form a complex, and this complex then binds to a receptor, as these are called, on the macrophage, and then it activates this cell called a macrophage, and a whole bunch of events happen here that result in the platelet being destroyed by the macrophage. And this is the destructive process of ITP, which is occurring in ITP patients. And there are many things here that we'll talk about in a minute that are components of this eating mechanism. And if you starve the macrophage of these substances, the macrophage doesn't ingest and destroy platelets. This is a different cartoon version I'll show you here. I used to be very muscular, and I'm still tall. Platelets are made in the bone marrow. They enter my circulation. And after about 7 to 10 days, they're removed from the circulation. by a process of dying. If ITP occurs, antibodies are made and they destroy platelets at a very large rate, usually in the organ called the spleen. For many years, it was thought that the bone marrow, shown here, increased the rate of platelet production to compensate, but that's probably not true. And in ITP, what happens, as I've intimated, is we have a problem of increased platelet destruction here and an inappropriate low rate of platelet production. The antibodies are removing platelets in the circulation and preventing the bone marrow from making more platelets from the megakaryocytes. So this is a megakaryocyte problem, and this is a macrophage problem. So dear mother, let's remember, megakaryocytes make platelets and macrophages destroy them. So if one looks at how the ITP disease is being approached, there are many different ways to treat ITP, and this is an overview of some of them. I'm going to only talk about a few lest we confuse the audience here, but basically you can take a monoclonal antibody such as rituximab or similar things to it, and it will bind to a different thing than rituximab does, and this reduces the cells that make antibodies. You can take another monoclonal antibody that inhibits the cells that make antibodies called plasma cells. You can give patients chemicals that inhibit the production of antibody production by plasma cells. And all of these are attempts to decrease the immune system to prevent it from making antibodies that are attacking platelets. I will discuss a neat new pathway, which is called the neonatal. So FcRn stands for the neonatal receptor. This is a pathway by which antibody for many billions of years was passed from mother to baby. But there's now a way to use this to target ITP. And by targeting this pathway, we simply decrease the anti-platelet antibody, which is in the circulation of patients such as those in the audience here. If we focus on other approaches, we can turn off macrophages by giving them IVIG, and many of you have had IVIG, but it turns out that only a small percentage of IVIG is chemically active in this process, and that's what's called hypersialate. It's got a lot of sugar on it. So IVIG, it contains a lot of sugar on its surface, is much more active than the IVIG that lacks that. You can chemically make IVIG that has a lot more sugar on the surface of the protein. This is a very active form, and it turns off the macrophages in our system. Furthermore, it turns out that in the antibody, it's got two parts of the antibody. One is called the Fc part of the antibody. The Fc part of the antibody is the only part of IVIG that's chemically necessary to make the platelet count rise in ITP. And what you can do is you can, in the test tube, make this part of the antibody, and it turns off the consumption of platelets by the macrophages. And then there's a chemical that we've been working on called a Bruton tyrosine kinase inhibitor. This is a pill you can take that actually turns off the ability of the macrophage to chew up platelets. So these are all efforts here that we'll talk about, some of which we'll talk about. Then there's a new approach to ITP that is using a substance called complement. And I'll describe in more detail at a motherly level what complement means in a second, but they're antibodies against complement. So all of the things I've described here so far are things that turn off the rate of destruction of platelets, and I'll talk about a few of these. I don't have time to talk about agents that increase the rate of platelet production, that make the megakaryocyte make more antibodies. And these are novel products such as recombinant thrombopoietin, which does work in pregnancy. I won't talk about the new thrombopoietin pills you can take that are being developed, and I also won't talk about a really neat technology, which is giving a patient, or in this case, an animal, what's called low-level laser light. All of these are things that increase the rate of platelet production and might be amenable for treating patients with ITP. And certainly, you all know that the thrombopoietin receptor agonists have been very helpful in treating ITP. So I'm going to focus on three topics. I'm going to talk about the neonatal FcRn pathway shown here. I will talk about this drug called Bruton's tyrosine kinase, and I'll talk about complement in a few minutes. And again, my goal is to give you an overview of how we're going to try to approach ITP as novel therapies, and also tell you where these developments are going in the course of this discussion. So let's talk about the neonatal FcRn pathway. There are a whole bunch of drugs being developed, and they have wonderful names. This is like a Lord of the Rings tale: efgartigimod, rosanzolizumab, nipocalimab. These are all wonderful new drugs being developed, and these are all what are called monoclonal antibodies that attack this pathway and turn it off. So let's go back over what I'm talking about here. This is our cartoon. Here's a platelet. Here are antibodies that will bind to the platelet. But if you could make the antibody disappear by inhibiting a process called the FcRn pathway, if you could make these antibodies disappear, then the ITP is fixed. Now, it's important to note that many people like me who are real old treated ITP 50 years ago with a device called plasmapheresis, which is a machine like a dialysis machine that makes antibodies disappear. This is a very cumbersome approach to ITP. It works, but it's not very convenient. But by having a medication that makes the antibodies disappear without hooking a patient up to a machine, this may be a markedly new way to treat ITP. So, dear mother, in blue here is the antibody molecule. This is the part that binds the platelet, but this part of the antibody molecule binds to these red things called the neonatal Fc receptor. And what this does is it binds to the antibody and makes it live very long. So normally, if an antibody doesn't have the participation of these neonatal Fc receptors, it lives for 1 day. But if receptors are present, the antibody is preserved and it lives for 28 days. So this is a target for therapy, as we'll talk about in a second. This receptor is present in placenta. This is how mothers give babies antibody. It's also present in a wide variety of cells, one of which is called the endothelial cell. Now, endothelial cells are the lining of your blood vessels. The total amount of endothelial cells is the equivalent of 2 American football fields. I don't know what that translates into soccer fields, but basically endothelial cells are present in abundance in our blood vessels. And every day, the endothelial cells are chewing up a bit of the liquid part of the blood called plasma. And here's an endothelial cell shown here. Here's the bloodstream here. This cell imbibes, it eats or chews some of the plasma, and it removes about a unit of about a liter of plasma a day. The plasma contains antibodies and other proteins. They enter this what's called vesicle, and the pH drops to a very low pH. The antibodies bind to this lovely receptor in red here, but the other proteins don't, and they then get degraded. The antibody is protected and recycles to the surface and has a very long lifespan. Now, the therapy I'm talking about here is an anti-FcRn antibody. This is a monoclonal antibody which targets this receptor and turns it off. So what happens in a patient who has received this antibody therapy, these receptors don't bind either the good antibody or the anti-platelet antibody here, and both the good antibody and the anti-platelet antibody are destroyed, and we decrease the amount of normal antibody and the amount of pathologic antibody. And they're both decreased to a similar degree by this technology. This is that list I showed you a minute ago of different molecules under development. I mentioned rosanzaliximab, and I'll talk about in a second. I shall also mention the other Lord of the Rings type molecule called efgartigimod, was just approved in the United States for a different autoimmune disease. So these molecules are showing that they are effective in a wide variety of autoimmune conditions, of which ITP is one. So let's look at rosanzaliximab and see what that tells us about this particular therapy for ITP. So many of you have probably not participated in a clinical study. This is an early, what's called phase 2 clinical trial, and this selects patients with ITP who've had ITP for more than 6 months, whose platelet counts are under 30,000. And in the clinical study, we test different doses of drugs. This group of patients got 4 milligrams per kilogram weekly for 5 weeks. This one got a higher dose for 3 weeks. And here's a group that got a single dose of 20 milligrams times 1. So patients came on to the study, they have ITP, they're given different doses of this molecule. And the question is, what happens? And the major goal in most treatments in ITP studies is to make the platelet count go above 50,000. And what happens here is if we give rosanzaliximab to these ITP patients, I'm only going to focus in the purple on those that got the highest dose. What happens is by day 8, the amount of antibody in the circulation drops by 70%. The good antibody drops by 70%, and the anti-platelet antibody drops by 70%. And the question is, did this make a difference in the platelet count? And lo and behold, more than half of the patients shown here in purple who got this high dose, and some at the lower dose, maybe 2/3 of patients, had their platelet count rise over 50,000, which meant they responded to this form of therapy. And if one goes back to the platelet count rise, again, I'm going to focus only on those patients who got the higher dose. What happens is they started a platelet count of 20,000, but by day 8, a rather rapid response, the platelet count rises to 140,000. And this is when the antibody levels have become very low. As I showed you in a previous slide, when the antibody levels come back, then the platelet count drops again. But this is a very effective therapy that's being studied. Now, the question about ITP treatments, and since I helped develop many of these things, as a doctor, I'd love to prove the platelet count rises, as with many patients. But for a patient, it's important in a clinical study to actually ask the question, well, my platelet count may rise, but am I going to pay a price for this? Do I get other side effects? And what's good about studies, and it's good to show these kinds of complicated slides, is the side effects are rather modest. At most, about 1/3 of patients had a headache, 12% had diarrhea, 9% had vomiting. These are all what are called low grade. It happened at a very low level, but it's reported here over this study. So by inhibiting this receptor called the neonatal receptor, this is like putting patients on the machine that sucked off the antibody, but it lets us do it every day. And there are now what are called phase 3 studies, which are studies that will result in the licensing of these drugs that are ongoing right now. Some of these are ongoing in Australia and many other countries. So, dear mother, I hope you're still awake, but let me tell you about another neat molecule called the Bruton kinase inhibitor. Going back to my cartoon, which I think you now know, here's a platelet. Antibodies come along, they bind to the platelet. The platelet then binds to a thing called a receptor on this cell called the macrophage, and a whole bunch of things are activated. I'm not going to go into these in great detail, but these are all different events that need to happen for this platelet to be ingested. And if you, for example, inhibit this thing here called a Bruton tyrosine kinase, what happens is this internalization does not happen. So this is called a BTK inhibitor. There's one that's under clinical trials right now. And it is named after a guy named Ogden Bruton. This is his World War II picture. He discovered that some kids have a mutation that caused them to be severely immune deficient. They had increased risk of infection, and they also had decreased risk of autoimmune diseases. So basically, if you lack this mutation, you don't have autoimmunity, and you don't have immunity, period. So this is a slide I probably should not show to my mother, but the Bruton kinase is a very important molecule in medicine. This is a lymphocyte right here, and for a lymphocyte to grow, it requires BTK, and if you inhibit BTK, lymphocytes tend to disappear, and that's what's called a B cell over here. We're going to focus on this cell that I talked about before called the macrophage. This is a macrophage, and here's the platelets that are going to be eaten up by the macrophage. We've got to activate this macrophage, and it requires Bruton kinase to be activated. And what I'm going to show you is if you inhibit Bruton kinase here, the macrophage does not chew up platelets, and you have a nice response to your ITP. Too complex, but let me just show you one last cartoon. Here's the Bruton kinase in cartoon fashion, and here's this drug called rilzabrutinib. This is a chemical that you eat. It binds to this what's called tyrosine kinase or Bruton kinase, and it turns it off. There are about 250 of these things called kinases in your body, and this Bruton kinase is highly selective. It only attacks the BTK and maybe 4 or 5 others to a lesser extent. And this is a very what's called selective molecule. Also, when one has a drug on board, you don't want side effects of the drug, and basically this drug disappears from your circulation in 5 hours. but it does inhibit this thing called Bruton kinase for a whole 24 hours. So this is a pill one takes once or twice a day to turn off Bruton kinase. So this is another design of a clinical study, and maybe some of you participated. I know we have several patients from Australia in the study. We took patients of 18 to 80 years old. They had to have had a prior response to some ITP therapy. They required 2 platelet counts less than 30,000, and then we gave them different doses of this pill, either a single pill of 200 milligrams, a single pill of 400 milligrams, or a single pill, or 2 pills of 300 or 400 milligrams twice a day. And when one does a clinical study, one looks for safety endpoints. Did people's hair turn green or blue? But we also look for what's called efficacy endpoints. Did it work? And the efficacy endpoint in this study was, did the platelet count, which was below 30,000, go above 50,000 on 2 consecutive weeks in the study? And if it did, these patients then could enter what's called a long-term extension study, where they get the drug in perpetuity if it's working. So here's the study, 60 patients. A small number got lower doses, but I'm going to focus on those that got the highest dose, 45 patients here. I'll talk about what happens to these patients. And then many of these patients, 13, joined 3 responders from this group. We have 16 patients entering a long-term extension study to ask how good does the drug work long-term. This is what ITP patients look like, and they're probably like many of the people in the audience. The people started at the highest dose of 400 milligrams twice a day, had a median age. Now remember, a mean age is the average age. A median age is the age of which there's half higher and half lower. So basically the median age here is 50 years old. A little over half of the patients were female. The median duration of ITP was 6.1 years. So these patients had been through the ITP ringer, so to speak. Their median platelet count was 15,000, and they'd failed at least 4 prior therapies. 24% had actually failed splenectomy. So this is a group of patients who were the outlier patients. They had a long duration of ITP, had not responded to prior therapies, at least 4 of which. So the question comes, we look at the 45 patients entering at this high dose level here. What happened? 18 patients, 40% responded. Of these 18 patients, 16 responded within 8 days of starting therapy. And showing down here, this is the 24-week study. Non-responders, nothing happened. But the responding patients, 40%, had a nice response that began by day 8 with a platelet count rise. If you analyze how good was the response here, the platelet count was over 30,000, 95% of the weeks. The platelet count was over 50,000 on 72% of the weeks. So basically, we have really bad ITP patients with a very high response rate, and the number of days on study for that 24-week, very high rate of maintaining an adequate platelet count. So this is all good results. We then ask, well, did it matter whether these were young patients, old patients, on some other therapy, splenectomy or not? And the bottom line is that I'm not going to go over the details here, that if you were splenectomized or not splenectomized, if you had multiple or few prior therapies, pretty much the response rate were over 30%, oftentimes higher, independent of what prior therapy that patient had been on. So this drug seemed to work in everybody, in all comers. Now, what happens if we continue the study? And as I said, 16 patients entered what's called a long-term extension study. And what's happening here is that this is the platelet count rise. This is just the responders. And if you ask what happens over the next 1 to 2 years, they maintain that platelet count with maybe 1 patient coming off down here. But basically the platelet counts in the next, on average about a year, were over 30,000, 100% of the weeks, over 50,000 on a median of 90% per week. So this is a high response rate group here, and they maintain that response for a long period of time. Now, as I said before, that the enthusiasm for response always has to be tempered by whether there's side effects. And we grade side effects grade 1 through grade 5. Grade 5 is you die, a grade 4 is you're in a hospital, but grades 1 and 2 are pretty mild side effects. And that's all we saw with this drug. And the side effects were typical diarrhea, a bit of nausea and some fatigue, but this was a well-tolerated drug for patients on this study. So where is this going? Well, this drug certainly turns off your macrophage chewing of platelets. It may reduce antibody production long-term, and there's a large phase 3 clinical trial underway right now, which I believe is also ongoing in Australia by my colleagues there to assess its long-term efficacy. So, dear mother, if you're still with me, I'm going to tell you one more tidbit about ITP, and then we're going to close. I'm going to talk to you about complement. And complement is not a thing that we give to our friends in terms of reflecting upon their clothing or their face. Complement is a substance which amplifies the antibody scheme, and I'll tell you about that in a second. And the drug we'll talk about is a name called sutimlimab. Going back to our molecular cartoon, here's a platelet. Antibodies come along, they bind to the platelet, and I said before that these antibodies go to the macrophage in the spleen and are destroyed, but there's another mechanism. When you have an antibody like this, it fixes a thing called complement. And complement is like tossing gasoline onto a fire. If the fire is here, tossing gasoline on it, which is complement, makes the immune system much more robust. And what happens is these platelets are then destroyed primarily in the liver by things in the liver we won't talk about. But this is a complement scheme. So complement is the energy we add to our immune system to make it work better. And this is a slide I probably would never have shown to my mother, but I'll show it anyhow. But when antibodies bind to a platelet, that's called a classical immune system. So the classical immune system takes the platelet to the spleen. But if the classical immune system gets activated with complement, then the platelet also contains a thing called C3, and it contains a thing called C5, and a thing called C9. And as I'll describe in a minute, when the platelets now have C3 on board, they're removed by the liver. And if they have C9 on board, the platelet just explodes into circulation and is lysed inside your body. We've known about complement for many years, but it's only recently been resurrected. This is a study from 1985, a while ago. And it basically showed that normal platelets shown here, shown here, shown here, and shown here don't contain complement on their surface. But ITP platelets here, and here, and here, and here do. And this is old data, which has now been replicated in more recent times, showing that platelets in ITP patients have this stuff called complement on the surface. Now, why is this important? It's because there are drugs we now have that can turn off complement. This drug called sutimlimab actually blocks this first step in complement and prevents all the other things from happening. And this is a drug that we've tested in other autoimmune conditions. And I'll describe how we tested it in ITP in a moment. So let's go back to one last model, and I hope my mom's still awake here, but basically here is antibodies binding to platelets. As I said before, classically, they then went to the spleen where macrophages destroyed the platelet. But if the platelet and antibody substance has complement added, then this thing called C3b binds to the platelet, it tracks the liver and is destroyed in the liver. A few of these platelets may add a thing called C9 and go pop in the circulation, but that has not been studied much recently. So here's our last clinical study. This is a small study of 12 patients. These are typical ITP patients, platelet counts under 30,000. They're given drug for 8 weeks. They then come off study and don't get drug. Then they go back on drug. And what's shown here is that if you look at who responds, about 40% of patients had a response, meaning the platelet count rose over 50,000 in this study. And here's the time course. Patients come on a study, they get drug, their platelet count rises, they remain on study for the duration of the study, they come off the drug, their platelet counts fall, they go back on drug, and their platelet counts rise. So this nicely shows that by inhibiting this stuff called complement in these 12 patients, we've actually improved their response rate. The blue line here just shows that here's the high levels of complement before the study. The levels of complement drop when the drug is given. We stop the drug, complement levels rise, platelet counts fall. And when we restart the drug, the complement levels drop again and the patients do well. So this is a very new therapy for ITP, and it's a new attack of how we treat ITP. So to summarize, where we're going with this is that complement may play a role in half of patients with ITP. This drug called sutimlimab, which will soon be licensed in North America for a different immune disease, may turn this off in many patients, and phase 3 studies are being planned for this disease. So let me conclude this discussion, hoping my mother is still awake and listening. There are a lot of different things we're testing in ITP to make this disease get better. We're using monoclonal antibodies and chemicals that may alter the production of antibodies by the immune system. I've already shown you that inhibiting this thing called the neonatal FC receptor may physically make the antibody disappear. Next time we meet, I should talk about the fact that IVIG can be modified to make it a super IVIG, either by putting more sugars on it or by chemically changing its structure. I did show you the bruton kinase, a drug called rilzabrutinib, is a pill you can take that reduces the consumption of platelets by macrophages. And any of these molecules may affect the underlying immune process and be a good treatment for ITP. I mentioned that the complement inhibitors are being studied in a lot of different systems, including ITP. We don't have much data on that yet. So these are all new efforts to decrease the rate of platelet destruction. What I'd like to do in the future years is talk to you about new efforts to increase the rate of platelet production by using recombinant thrombopoietin during pregnancy, by using some new oral thrombopoietin receptor agonists, one of which is called heterothrombopeg, which is being developed in China and soon in the United States, I think. And finally, to talk to you about a very exciting way to use light to actually treat ITP patients to make the platelet counts better. Problem we face right now is so far we've got no treatment yet that cures ITP. So on that, I'll stop and hope that I've given you an overview of what the lay of the land is for future therapies for ITP. Many of these are very exciting. Many are new options one has for treating ITP. And I look forward to meeting you again in the future and hope that my colleagues can address the questions you may have about this topic during the question and answer session. Thank you.